Good afternoon. Welcome to our session. I'd like to start first by thanking the International Osteoporosis Foundation and the World Congress for inviting us to present our panel today. I'm going to start out by introducing our panel, and then I'm going to go into my part of the presentation, and our panelists will do their presentations, and then we will have some time for open discussion. So with that, I will start by introducing myself. I am Dr. Rita Roy. I'm the CEO of the National Spine Health Foundation. I'm a general surgeon by training. I have been working in spine health for the last 6 years, working in patient-reported outcomes research, patient advocacy, and patient education. Joining me on the panel today is distinguished Professor Dr. Paul Anderson from the University of Wisconsin. Dr. Anderson is known for his prolific work in spine and bone health. You can read his full bio. Joining me also on the panel is Dr. Tom Schuler. Dr. Schuler is a spine surgeon from the Virginia Spine Institute, and he is chairman of the board of the National Spine Health Foundation. And finally, Dr. Ili Najjar, a spine surgeon from Nottingham, England. So, my part of the presentation is going to sort of set us up to talk about spine and bone health, focusing on the patient education groups that we are reaching out to. Talking about the impact of spine and bone health. And I've seen some of you who are here today at the Congress throughout this week, and one of the things that I've talked about is sort of the bifurcated pathways that we look at in spine and bone, and that is sort of the vertebral compression pathway and the pre-surgical optimization pathway. But when we zoom out and think about osteoporosis in the United States, at least, estimated 54 million Americans have low bone density, roughly equates to 2.5 million fractures. It's a $25 billion cost, healthcare cost in treating fragility fractures every year, and interestingly, more osteoporotic fractures occur in the spine than anywhere else in the body. Everybody here knows that, about 1.5 million times. So this is why we think it is really paramount that the National Spine Health Foundation really begin to tackle the issue of osteoporosis, osteopenia, low bone density. Why do we care? Maybe many of you have seen the paper that came out in January of this year in Osteoporosis International. The paper concludes that in men and women who are found to have VFs, opportunistically identified on routine CAT scans for other health conditions, the risk of death in those patients with those opportunistically identified VFs is 51% higher than those without the VFs. And when corrected for age and gender to the general population, that risk of death is 325% greater. Those are astounding numbers. So, like everybody at this conference knows, osteoporosis kills, right? Osteoporosis can kill you. And we believe it doesn't have to be this way. And so our approach to tackling this problem, helping to reduce these numbers, is through patient education. And we believe that patient education and awareness is the key to driving better outcomes with these devastating numbers. One of the things that we did this year is that thanks to support from both Amgen and UCB, we were able to produce a digital media campaign to drive this patient education. We did this on our digital media platforms. These are some of the infographics that we put out. We are on the internet, we are on Facebook, we're on Instagram, all the channels. And you can see we did some really very consumer-facing work. I think one of the things that's interesting and exciting about this is that while we are based in the United States, this is information that applies no matter where you are. And we are a global organization because we are in the digital universe. So I welcome everybody to follow us, come follow us, look at our website, find us on social media, and utilize our information. And I'm very proud to say that in the 3.5 weeks that we ran our digital media campaign on patient education and awareness, we had over 1 million people engage with this content. And so that was a very exciting outcome to see. Other work that we have done in patient education, our premier educational platform is called Spine Talks. It's sort of the TED Talks of spinal healthcare. We bring experts in long-form panel conversations. We've done 2 Spine Talks programs on osteoporosis and spine. We are launching a 3rd panel that's already been recorded, but it will launch on May 1st, where we will be in collaboration with the Bone Health and Osteoporosis Foundation in the United States, celebrating Osteoporosis Awareness Month. And in addition to that, we created a special edition of our Spine Health Journal, and you all have a flyer version of that on your chairs. There's a QR code. It'll take you to the full journal. If anybody wants a hard copy of the journal, I've got extras here today. And that journal is pretty spectacular. I'm going to let Dr. Anderson talk about that more when he comes to the podium here. This is just a little bit of information about our website at spinehealth.org. We do all of the things in digital media to SEO performance on our website, and just in December we're reporting numbers on 12 million viewers of our website. We celebrate and high-five ourselves on those numbers, but we are just scratching the surface, right? We know we are just scratching the surface, and there's so much work to be done, and we are grateful to supporters of our organization who help make this work possible. And with that, I'm going to tee it up for Dr. Schuler to get into further discussion on that.
If you take a look at America, where a population is just over 300 million, a third of our country is having problems with bone densities. And you look at the cost of it, it's staggering. When you look at spine issues, spinal problems are the #1 cause of disability around the world, as well as through the United States. And the question is, what can we do about it? And the answer is we can do a lot. The entire field of spinal health care has been transformed in the past 3 decades, and the technology that we have now to improve lives, to restore lives, is staggering. Whether we're talking about improving bone health and trying to prevent fragility fractures, or enabling us to implement the amazing technologies that we have to restore lives with people that have proper bone density, it is truly transformative. And so it's something that we all need to be working on to say, how do we optimize bone health so that we can optimize everybody's individual health? And that's really what we're working on through the foundation. When you talk about opioids, opioid use is a huge problem because of spine problems. So again, treating spine problems enables us to overcome the opioid epidemic. And we can't treat many spine problems if we don't have healthy bones. So getting the bones healthy is just a critical part of it. The spine is the #1 site for osteoporotic fractures, so something you all know, but it's very clear that this is an area we have to focus on. And it's the #1 reason for people to see physicians outside the common flu, but it's a very common reason to go. So the question is, what can we do about it? The National Spine Health Foundation is the only organization that is focused on patient education, is focused on the patients. We have amazing professional societies, but they're focused on the providers' education. We are focused on educating the public, because ultimately it's the public's questions that are going to drive the transformation of healthcare to get people what they need. And so working with the patients to help them understand what treatments are available, what treatments can make them better, leads to questions, which ultimately provokes the providers to say, okay, we need to transform. We can't keep doing what we learned in our training. We can't keep doing stuff that may be outdated. Because of the extremely rapid evolution of technology, we have new treatments that are available that are able to restore lives and improve lives. And so we need to say, at what point do we engage them and use these technologies to save our patients? And so by being a patient-centered education, we are the go-to source. And for comparison, we are the American Heart Association of Spine. We are the American Cancer Society of Spine. And we ultimately, our goal is to be the Spine Health Foundation to the world and work on all countries and provide that information to everyone. We try to help people understand what works, what doesn't work, and ultimately our goal is to empower individuals with knowledge and hope. We've created a distinguished board of leaders in the field And these are all neurosurgeons and orthopedic spine surgeons currently, and we're going to expand beyond this to providers from all arrays of the spinal health arena. But these are the top names in the United States currently that are working to help improve the education of patients and speak to patients in their terms, in their language, so that they can understand. When we take a look at osteoporotic compression fractures, we all know that in the women, this is a huge problem. But in reality, it affects far beyond women directly and indirectly. It is also a problem for men, and it's often overlooked that men need treatment too. And I think that as our diets change, as our societal activities change, that we're seeing a rise in men. And so it's important for us to understand this is not just a disease of women. It's a disease of everybody. And then you have the indirect effect that when someone's spouse, coworker, parent, child is affected, that it affects all of us. And so the trickle down is far greater than the numbers that are on the slide. When we take a look at the number of hospitalizations due to spinal fractures, it's staggering. But to me, it's far greater than that because that's at the cataclysm of the problem. What happens to the silent problem, because osteoporosis is a silent disease, that we are able to treat problems if people had the right bone density. And now that disc arthroplasty is becoming a mainstay, there are people that can have their lives restored and improved, but not if they don't have the right bone density. And so when we take a look at the number of people that need treatment, it far transcends the number of people with fractures. Because degenerative spine problems that are truly part of that number one disabling cause of people can be treated, but we need good bone density to be able to implement the miraculous technologies that exist today. I believe, and I've been a spinal surgeon for 32 years, that all patients who are undergoing a spinal instrumentation procedure, whether it's a fusion, a disc arthroplasty, or whatever, that they should have a bone density tested before they have their treatment. And I'm not just talking about the 50-plus crowd, the 60-plus crowd, the women crowd. I believe that they all should be done. And it's something that we have done at our institution for decades. And what we have seen is that there is an epidemic of osteoporosis in the United States, and it affects both men and women. And I have incredibly healthy individuals come into me that when I check their bone density, in spite of being 45 years of age and being a male, that they're osteoporotic. And getting them the treatment is challenging because everybody goes, well, they haven't had a fracture yet, so we're not going to initiate treatment. Well, they haven't complained of anything. We're not going to initiate treatment. So I, as a spinal surgeon who currently is not providing the medications that can reform the bone, I'm having a hard time getting my colleagues to support it and to say, what can I do to prevent the fracture? And to me, once we have the fracture, we've waited too long. And it's a question of saying, how do we prevent the fracture? Because once the cart's out of the barn, it's too late. We got to get the fracture treated early to preserve the biomechanics of the spine and get the best result for our patients. And then there's a whole separate issue of we have to be able to have strong bones to implement the technologies that we have, and whether it's specific instrumentation or ultimately where we do a disc replacement where we're relying on the end plates to support the devices. And so we need strong bones and able to do that. And these numbers are going to go up significantly in terms of people that can benefit from this treatment and need this treatment as it becomes mainstay across the world. We have prioritized our efforts on patient education, but at the same time, we are educating providers. We're helping providers understand that there is a better way. And as we speak to patients in their language, it also is the same language that providers can understand. And with us educating the public, we are also having providers learn from the same material. The journal that Dr. Anderson and his team produced is something which is providing information not just to the patients, but especially to the providers. And for many providers, this is the first time they're getting a resource which really compiles all the information about osteoporosis treatment in one form that they can understand and consume. So we are doing a great deal of provider education, even though that is not the primary goal of our organization. It is a definite secondary benefit, which is critical to improve spinal health care. Ultimately, this task force that we're presenting today is focused on osteoporosis, but we at the organization are focused on all aspects of spinal health care. We did create the task force, which Paul and Dr. Dymar are leading, and at this point, I'm going to turn the platform over to Dr. Anderson.
Thank you, Tom. And again, just to review, this task force is both ortho and neurosurgeons from the United States. And the Spine Health Journal, which was created as a patient education tool because we didn't really have anything to give patients about osteoporosis. We actually have a lot of spine stuff, but not anything in osteoporosis, at least in the spine clinics. And this is free. You can download it and give it to your patients. And that was the goal of this, is to make this available for patients to educate themselves about osteoporosis and try to convince them to follow through with our recommendations. And any input you would have on that, on how to improve it, please let us know. Keep in mind, it was set up for the United States, so it may not always apply to whatever country you're from in terms of what their current guidelines are, but this is really based on U.S.-based guidelines. But frankly, U.S.-based guidelines, to me, are very similar to what I've heard all week at the IOF and from various countries, so it probably pretty much applies. So what I'm going to talk now about is, what do you do with that preoperative patient that Dr. Schuler was just talking about, and how do we decide whether to get them treated for their osteoporosis before we proceed with surgery, and also what is the justification for even thinking about doing that? So this is my perspective as a spine surgeon, although I've been doing research in osteoporosis for 30 years, and these are just some of the bad things that might happen to our patients. I have financial closure. I'm a consultant for several of the drug manufacturers, and I get research support from a clinical trial. So the objectives are to understand bone health on outcomes of spine surgery, and then to integrate screening for osteoporosis into your clinical practice as a spine surgeon. Frankly, this also applies to elective orthopedic procedures, particularly I think arthroplasties. The same problems occur there as do in the spine. Also, in those patients who do have deficits in their skeleton, how do we go about getting them better care and preoperatively optimizing them using a multidisciplinary team? First of all, how prevalent in the spine practice is osteoporosis? This is a meta-analysis published in PLOS ONE last year, and the prevalence worldwide was 34% of patients had World Health Organization criteria for osteoporosis. So 1 in 3 patients who are over the age of 50 coming to the spine practice have osteoporosis. It's obviously worse as you get older, and women are about twice as risk than men. And Asian countries are at a higher risk as well. And these are all things we know about fractures, and it's not new information. But again, 1 out of 3. Well, what happens if you have osteoporosis if you have one of our wonderful spine surgeons? Well, bad things happen. And I'm not going to go through this list, but all of those things are bad. And generally going to end up with revision surgery, even paraplegia in some cases. Some of these complications are that bad. And the odds ratio, comparing whether you have osteoporosis or not and have these spine procedures, is somewhere between 1.5 even up to 7.5 times the risk if you have osteoporosis. So clearly, osteoporosis is a major predictor of adverse outcomes in spine surgery, and it doesn't matter what outcome you're talking about. I'm going to review one study. It was from the Mayo Clinic. 140 patients had spine fusions. All of them had DEXA scans. And they just classified osteoporotic-related complications like kyphosis, pseudoarthrosis, fractures, and hardware failure. And it was almost a dose response between your category of osteoporosis and the chance of complications. So the osteoporotic patients, 50% of the patients Mayo Clinic had one of those complications. So that's an astounding number, and one that we can mitigate. We can do something about this if we can identify them and get them treated. So how do you identify patients? One way would be like Dr. Schuler suggests, he screens everybody for a DEXA. There's a problem with that, is that a lot of those patients are not being indicated by current guidelines for DEXA scans, so they may not be reimbursed for that. And also, there's probably going to be a lot of negative exams that the people who didn't need it. On the other hand, he's picking up a lot more cases. However, taking a slightly different approach, is basically applying current guidelines by the International Society for Clinical Densitometry, ACE, clinical endocrinology guidelines for who needs screening, and just apply those to the spine patients. So the first step is to determine who needs further bone health assessment, including a DEXA exam. It's not get everybody a DEXA, but just who should we get a DEXA on? And basically, we're using a modification of currently accepted guidelines. If you're a female over 65, male over 70, if you have a history of a fragility fracture after the age 50, and even orthopedic and neurosurgeons, although we may not know the nuances of osteoporosis, we should be able to identify fractures, especially orthopedic surgeons. I think we can identify that. And then if you have a high frax risk, now we don't have a BMD yet, so this would be without BMD. And this number, 8.4%, is one that is recommended by the United States Preventative Health Service Task Force. And it's really the chance of a 65-year-old female without any risk factors getting a major osteoporotic fracture within 10 years in the United States is 8.4%. Some people use a little bit higher number. And I think there are some European equivalents, although I don't know what that number is. But if you meet any of those criteria, then you should have a DEXA before your spine surgery. And this is usually done at the initial screening when you're thinking about doing spine surgery, although it could be applied to every patient, because part of the, as Tom mentioned, part of care is to not only improve whatever spine condition is, but to improve their skeleton also helps with their spine condition. I did two studies, one prospective, one retrospective study on the effectiveness of this screening tool, and the sensitivity was 100%. So if everybody who ultimately had osteoporosis met one of those 4 criteria, so you could screen and identify everybody with osteoporosis, specificity was 61%. So 39% were false positive screens, which for a screen test is pretty good. And most of the ones who were false positives were men over age of 70 who had, like farmers from Wisconsin, had these rock for bones. They clearly didn't need a DEXA scan. So what do you do if once you get a DEXA back? Well, then you classify their disease through the risk stratification. And we use the risk stratification that has been promoted in the United States by the Clinical Endocrinology, by Bone Health Osteoporosis Foundation, and it's also consistent, I think, with the IOF current recommendations, is you risk stratify into low risk, high risk, and very high risk. Low risk means they haven't had fractures and they have a good T-score and a low frax. The high risk are those patients who have a low T-score, in other words, less than minus 2.5 to minus 3, a major osteoporotic fracture risk of 20 to 30%, or they were osteopenic but had a distal radius fracture or some other fracture. Those would be high risk. And then the very high risk are really the ones that are going to need significant targeting. But those are the ones with multiple fractures, recent hip or spine fracture, high frac score, very low T-score, multiple fractures. Those patients, you need to step back and really consider those patients for a prolonged bone health optimization. Well, finally, what do we do when we have one of these high-risk or very high-risk patients? Well, we refer them to a bone health specialist team, the same team we would refer for secondary fracture prevention. And the process is identical to secondary fracture prevention. And we're going to typically use an anabolic medication. What does the bone health specialist do? In my hospital, this is done by our fracture liaison service that I run, but I have a nurse physician's assistant and nurse practitioners who do this, and they do all the things, like I said, for secondary fracture prevention. And then most of these patients are going to get treatment with an anabolic type of medication because we really want to build that bone as fast as possible. How is this effective? Well, if you look at randomized clinical trials of bisphosphonates, and most of these were IV bisphosphonates, 4 out of 6 trials were positive in favor of bisphosphonates in terms of the various outcomes that you might include in a study, such as clinical results, time to fusion, overall fusion success, and hardware with complications. 2 of them were negative studies in that there was no difference between the placebo and the bisphosphonate-treated group. So overall, bisphosphonates look to have a positive effect on bone healing, improved clinical outcomes, and prevented complications. There are more studies with teriparatide. I don't have any such studies with romosozumab or abaloparatide, but there are quite a few on teriparatide. Now there's only 2 of these are randomized controlled trials, the rest are retrospective kind of cohort studies. But the 2 randomized controlled trials, one from Europe by Jespersen, was a negative study. In other words, the placebo group did as well as the teriparatide group. The other one from Japan, Abeta, was very positive for teriparatide. So, a little bit conflicting evidence here. But there's probably a positive effect on bone healing in the spine fusion, unchanged clinical outcomes, and it did reduce bone-related complications. Just one study that recently was published, a very interesting one. These were people having multiple level fusions, 7 level fusions. These are highest risk patients. A lot of bad things happen when we do this, and this was out of New York City, and they compared the osteopenic untreated group to the osteoporotic group treated with teriparatide and looked at pseudoarthrosis, revision surgery, and kyphosis developing after surgery. And the pseudoarthrosis rate was half in the teriparatide group compared to the osteopenic group. So even though these people had worse bone, they had better outcomes with teriparatide. Revision surgery was 1/3 in the teriparatide group. So although the post-traumatic or proximal junction kyphosis was no different. So again, showed a very strong effect of osteoporosis, and this was given for 2 to 3 months before surgery and then continued for the full 2-year treatment after surgery, and then subsequently followed up with the bisphosphonate. So a lot of question about timing is, and we're really looking for what is the mechanical strength versus the biologic, and these anabolics have effect on both sides of that within 3 months. So a minimum of 3 months is kind of what we're looking for the surgical delay. But it does depend on the patient. If a patient has major neurologic deficit, you don't want to wait 3 months to get their bones better. We'll treat them post-op. And I'm not even sure if that's a bad thing. Maybe we don't need to treat them pre-op. I really don't know. Unfortunately, the evidence doesn't help. But you have to discuss, with the patient, is it worth the delay? What are the requirements? The bigger the operation, the better the bone better be, and so the longer the delay. So again, going back to risk stratification, low risk, we're going to proceed to surgery and optimize calcium, vitamin D. High risk, optimize calcium, vitamin D, and then you could consider an anti-resorptive for these patients without a surgical delay. However, if you're doing a really mega operation in a high-risk patient, maybe you'd want to do an anabolic treatment. And then finally, the very high risk, those patients clearly you need to stop, pause, and get those patients treated for considerable time with an anabolic beforehand. So, just to summarize, osteoporosis and spine surgery predicts complications, significant harm and cost, reduced quality of life, treatment's effective but rarely performed, and surgeons really need the help of the bone health specialists to help us identify these patients, how do we interpret DEXAs, and then to help us provide medical treatment. Thank you very much.
Thank you, Dr. Anderson. I'll pick it up from here, talking about the European perspective of osteoporotic fracture, especially as a spinal surgeon. I have no conflict of interest. Based on a study by Prof. Sahota from Queen's Medical Center, we know that around 100,000 patients were admitted in England due to osteoporotic vertebral fractures, and this is increasing annually by around 14%. Now, such patients will present to you with multiple problems, including pain, loss of function, they're bedridden, unable to mobilize, depression, unable to sleep. But as a spinal surgeon, there are two ways I can help them. I can offer an intervention for their pain when needed, and I need to think about their overall alignment and the deformity coming from such fractures. So the economic impact of such fractures in England is around 2.2 million bed days occupied for the past 3 years, and that's around 704 million pounds. And the trends are always going upward with a steeper slope for patients above 75. And the whole demographics of our patients is shifting recently for elderly patients. Although we have a lot of guidelines to manage those osteoporotic fractures, most importantly, the GIRFT guideline for England, Northern Ireland, and Wales states that if a patient is in unremitting pain, despite the adequate pain medication within 48 hours, he should be referred to a spinal unit. And within 72 hours after the MDT discussion, this patient should be offered vertebroplasty to get out of bed, get them moving, and move on. Yet, only 1.8% of the patients had their vertebroplasties. And if you consider this proportion in patients over 75 years old, this is even lower. And this is a problem because in a way, we are creating a vicious cycle. Those patients who did not undergo vertebroplasty, for example, are having around 10.8 median lengths of stay in the hospital compared to 2.4 days for the for those who had their vertebroplasty. What does this mean? Why are we underperforming? Simply because, for example, in our tertiary unit, we don't have beds to accept those patients, and we don't have theater capacity. And part of the reason we don't have beds is because osteoporotic patients are taking part of our beds. So this is a cycle. Now, when we talk about costing, we're seeing that the potential estimated cost saving for each patient who might benefit from vertebroplasty or with cement augmentation in general is around 1,400 pounds. That's 1,600 euros roughly. Now, we talked about the pain control part. What about the biomechanical burden of osteoporotic fractures for surgeons? It is a cause of concern because in one of our meta-analyses from our team, we showed that patients, when compared to a matched control group, patients with at least one osteoporotic vertebral fracture, the average was 1.4 vertebral fractures, had sagittal malalignment resulting from this fracture. What does the sagittal malalignment mean? It's simply they're losing stability. They're having to compensate by using the extensors, retroverting the pelvis, extending the hip, flexing the knees, dorsiflexing the ankles, and chronically that's a very high burden. Even some studies compared adult spinal deformity burden-wise on quality of life to chronic diseases such as arthritis, chronic lung disease, diabetes, and congestive heart failure. The difference is that those chronic diseases are very well studied, a lot is invested in them. Adult deformity is incomparable. So one of the things we can offer for treating pain is cement augmentation. But does it affect the sagittal malalignment? Would you regain balance after such operations? In another study from our group, a meta-analysis, for example, here, this is an example of kyphoplasty where you insert a balloon inside the fractured vertebra, inflate it, hoping that this would reduce the fracture, then fill the gap with cement. But does it actually reduce the fractures? The answer is no. So this meta-analysis showed that patients, despite balloon kyphoplasty, there was no significant change in their sagittal parameters. Now, what's the answer then? How can we help those patients regain alignment? Most of the time, unfortunately, the answer is a complicated surgery where you have to put screws. Sometimes you even have to do some osteotomies or cutting of the bone. And that's another catch-22. Why? Because the complications are very high in osteoporotic patients when it comes to mechanical failure. And Dr. Anderson has already discussed that. We know that the mechanical failure complications can go up to 37% in osteoporotic patients. Implant failure usually peaks at 12 to 24 months. Now, such failure can be due to proximal junctional kyphosis, adjacent segment disease, pseudoarthrosis. All are osteoporosis related. This is an example of one of our patients. We started with lumbar fixation, ended up with a proximal kyphosis and a large surgery with osteotomies. This is a major surgery. In patients whose osteoporosis is part of the physiological failure, it's not only osteoporosis. Those patients will come to you with multiple comorbidities. And I'm a spine surgeon. I honestly don't know how to manage most of those comorbidities. I need help. So when we're talking about identifying the problem from a surgeon perspective, we do know that DEXA scans are very important. But more and more, especially in our practice in Queens, we're starting to use CT scans regularly for patients pre-op, and now we're using Hansfield unit to identify patients who might benefit with management for osteoporosis. Why? Because most studies show that Hansfield unit is an independent influence for pedicle screw loosening. But most importantly, it is less affected by the degenerative spine, which can give you a false negative in DEXA scans and osteoporotic fractures, where you get calcifications. This is another study published in AO Spine, showing that Hansfield unit was the only independent predictor for osteoporosis-related complications, and you will get 3-fold increase in mechanical failure rate for every 50 points you lose from the Hansfield unit. Now, root cause problem solving, as we said, we need help as surgeons. And this is why the future is for multiple disciplinary approaches for such patients. It's not about the surgeon anymore. We're working with nutritionists, intensivists, anesthetists, geriatricians, physiotherapists, and we're all trying to come up with a common plan to optimize the patients and sometimes to know when to say no for the patients. Sometimes we will not be able to offer the results we can for such patients. Those are some pictures from our multidisciplinary meetings and ward rounds. And just to put things into perspective, in Queens Medical Center, we started our complex spine deformity MDT since 2021. We were hit by COVID. And out of the initial 59 patients discussed, we're talking about a small number because of COVID again. 42% of the patients were denied surgery because they required further optimization. If it was up to the surgeon, those patients would have been operated and came back with multiple problems. But most importantly, we're still having around 15% of those patients denied surgery completely because we think we cannot optimize you much. And weighing risks and benefits, it's not a good idea to have major surgeries now. Finally, I'm not gonna repeat those. Dr. Anderson already spoke about the teriparatides and optimizing bone quality. And this is my presentation. I hope it was helpful. Those are my references, and thank you.
Upinder Sahota, UK. So thank you very much. Excellent talk, and thank you very much for just raising this issue and with the profile. What you've really nicely demonstrated is obviously this high-risk group of patients who have osteoporosis you've identified and need major surgical intervention. However, one of the challenges that we have is that these drugs aren't licensed, particularly the anabolics, in patients who are what we would deem as low risk. So you've got, as you've said, you've actually done a DEXA scan. The DEXA scan shows they've got osteoporosis, but they've got no vertebral fractures, but you're planning major spinal surgery. So our biggest challenge, particularly with the drug authorities that we have and the licensings, is that how do we convince them that these people need anabolic treatment because they're planning major surgery? And that's our bigger challenge that we still have. And just grateful for the panel towards their thoughts. Thank you.
Program I set out, or I described, is basically, at least as for the United States, is on-label use of those anabolics for the most part. So we have less problem getting those very high risk, because we use the risk stratification, and very high risk patients is an anabolic is a approved first-line drug. So we try to identify those patients. Now, we also use, you have to use some detective work. First of all, you have to be very cognizant of the history and really ask about other fractures. Other fractures, a prior fracture after the age of, within 3 years of your upcoming arthroplasty or spine fusion, predicts a 5 times higher rate of periprosthetic fracture, fracture around the spine fusion, and a 7 times risk of other fragility fractures. So you have to start asking about other fractures, and that will help us make the case to the insurers. Another thing we use, as Eli just talked about, is Hounsfield units. For those not knowing exactly what that is the X-ray attenuation of the irradiated tissue on a CT scan. You can draw a region of interest on any place, and it'll tell you what the average Hounsfield units is. A healthy adult male would have a Hounsfield unit of the spine around 200 to 250. If your Hounsfield units are less than 110, that correlates with about a 90% chance of having osteoporosis. And so using opportunistic CT, either if it was done specifically to help you plan surgery or diagnose the spine condition, or if the patient came in and had a kidney stone evaluation, a CT scan, you can use that equally well. And we have found that utilizing the threshold of 110, it's pretty well established and recognized, has helped us get approval for drugs. Another one is to use the trabecular bone score adjustment that's available in FRAX during the DEXA. So if you have a DEXA scan for a spine patient, you should specifically try to get a VFA, vertebral fracture assessment, because that can help identify a fracture, and trabecular bone score. And those patients who have degraded trabecular bone scores, that depending on their other risk factors, can significantly raise their fracture risk on FRAX and meet the threshold for very high risk. But keep in mind that the bisphosphonates also are very helpful in this, so we don't necessarily need an anabolic. I would prefer it, but the bisphosphonates, particularly I think IV zoledronic acid, I don't know about denosumab in this situation, as it has not been studied, but the bisphosphonates are effective alternatives.
So just following up on the Hounsfield unit, just a little refresher for everybody. Hounsfield was the guy who actually invented the CT scan. And so he applied the unit to it. And so it's a unit of his name. It doesn't have some other units. And we just published a paper with multiple meetings, including this meeting, that through the foundation that shows that if you look at a Hounsfield unit of 135, that you have a statistically significant increased chance of subsidence in spite of normal bone densities. And it's very common to get a normal bone density due to the measurement of the degenerative changes, the sclerotic bone at the edge of the bone, and not truly measure the strength of the internal bone. So the Hounsfield units is a great way to look, and there's now data out there showing increased risk of subsidence, which leads to biomechanical changes, which leads to surgical failure, and so a lot of support there. Having said that, we understand the political issues with getting authorization from governmental issues or insurance companies, third-party payers. And so part of our mission at the foundation is to educate people so that this overcomes in the future. Now, that may not affect your given patient at hand, but if we do enough of this, it'll change it for future generations and help implement change.
And I'd like to just comment on that also from the patient advocacy standpoint. So we've seen in the United States that organizations that work hard to advocate in disease states, for example, breast cancer, arthritis, leukemia, Alzheimer's, that when we can amplify the patient voice, we can make inroads to legislators and to payers. And so that's really what a huge part of our mission is at the National Spine Health Foundation is to amplify the patient voice so that patients can drive these conversations, not only with their physicians, but also make that case on Capitol Hill, make that case to payers. So I wanted to just mention to the crowd here, we've created a coalition in the United States. It's the Spine Health Coalition with the professional spine societies. And as Dr. Schuler had mentioned earlier, the professional spine societies do a fantastic job of taking care of their members. In fact, Dr. Anderson has been the past president of a number of these societies. But the societies recognize the importance of patient education, but it's not in their wheelhouse to do it. So they've partnered with the National Spine Health Foundation to be their partner. So we bring the voice and the work of the experts to the National Spine Health Foundation to drive our education and to drive our mission. I also wanted to just point out that with the Bone Health Task Force that we created in the National Spine Health Foundation, I think I might have mentioned failed to mention this, but Dr. Anderson, along with Dr. John Dymar, are the co-chairs of that task force, and they are volunteering their time to help create these materials for us and to figure out the strategy, the right approach to doing this. And so we're very grateful to that leadership and invite you all to take a look at what we're doing and reach out to me. So.
I get a lot of questions about how do you monitor change if you're doing this pre-op optimization. Surgeons are pretty simple-minded. Things tend to be black and white for us. Normally, if we're looking at something optimized, let's look at blood sugars, we would say, okay, what blood sugar do you want us to have this patient at, and we'll operate. And so I get the question, do we shoot for a bone mineral density improvement, a certain threshold? What about bone turnover markers? Do we use those or any other type of measurement? Well, you can't measure anything in the short period of time we're talking about for bone health. As you probably are all aware, 3 months changes are typically not even measurable on DEXA because the error in the DEXA is greater than the change would be. And so all we can go on is the known changes in the skeleton based on the multiple randomized controlled trials that have been done, particularly looking at the placebo groups as well as the treated groups, and get an idea of when are we seeing mechanical effects, when are we seeing biologic effects. And as I mentioned, it's around 3 months we're seeing both mechanical and biological effects. Now, they may not be statistically significant at 3 months because those studies were not powered for a 3-month time point, but they are measurable and they look like they're occurring. So that's why we assume a minimum of 3 months, although it is based on the severity of the patient's osteoporosis as well as the bigness of the operation we're doing, where we may need to go longer.
Your aim is to have good screw purchase. To do that, you can either increase the surface area through increasing the diameter, the length. Sometimes it's small changes in the screw itself, like hydroxyapatite and cement augmentation. And to prevent proximal junction kyphosis, again, there's a lot of studies. Some of them depend on how much you correct. Sometimes you put cement even in the 1+, the fixed level. There are new where you can use wiring to prevent major motion at that segment. So there are a lot of things we can do. Most practically is cement use and adjusting the size of the screws when possible, and sometimes the direction of your screw.
But frankly, you'll get a bigger bang for your buck by treating the bone and improving the bone than all those other things. And all those other things are not a guarantee of success whatsoever. And it just makes it more complicated for the next operation.
Yeah, gravity's a problem, and so, we may have to extend the number of levels we're treating to get a biomechanical advantage, whereas if you have strong bones, you may be able to shorten your construct, depending on what you're treating and why you're treating it.
Yeah, another effect that is not talked about as much as osteoporotic patients, their mesenchymal stem cells are senescent and they're lower in numbers. They do not like to differentiate into the osteoblastic lineage, And so there is an inherent increased risk of non-union of these big operations. So although he is correct that one approach is to, let's add some more screws, but we're also biologically making this a much more demanding operation. And that's why the anabolics make a lot of sense to me, because we are trying to not only work on the mechanical strength, but also the biologic, because we know those drugs affect the osteoblastic differentiation. So that's a secondary positive effect of those drugs.
One of the things we do in Cambridge with our Phoenix study is just hand out a simple form for everyone going in the CT scanner. Would you like to know your bone health? And after that, yes or no, the FRAX questions put into ways that they can answer very easily with height, weight, previous fracture, whether on a bone medication by describing it. Do you have infusions for your bones? Do you have tablets that need you to stand up once a week to take them? And then where were you born, and what's your current race, so that you can put it into the correct part of FRAX. And then, though you use Hounsfield units, what we can do, because we've calibrated most of East Anglia's CT scanners with a simple pair of phantoms, it doesn't matter where in East Anglia someone has a CT scan, you can then measure the BMD in true units of BMD, put it into the FRAX score as a drop-down box that says QCT of the hip, and put the number in. And with FRAX Plus now, you can put the multipliers in, which then say they've had a recent spine fracture. And that multiplies you up, and that often puts you into that anabolic first strategy, the very high risk category that you want. Now, I'm only saying this because these are all very difficult dots to join up. But from the spine surgeon's point of view, it's all the information you need to know in one. It doesn't need anything particular in order to get that aligned into a direct, really high-risk patient, because also, as well as the hip risk, you have the spine actual trabecular VBMD. And the recent study just showed that Hounsfield units are good, VBMD is very good at a 62 milligrams per centimeter cube, was a very high sensitivity specificity for fracture. So the trouble is connecting all those things up. And I'd just like your perspectives on it.
Well, I think what you're mentioning is the opportunities that machine learning, artificial intelligence offers. There's a whole new field of radiology. It's called radiomics, which is to quantitatively analyze data from imaging studies. And just like he mentioned, you can take a CT scan and calculate, and you can do it with phantoms or even without phantoms, calculate volumetric BMD. That is distinctly different than aerial BMD that we obtain from DEXA. But the volume BMD can be included into FRAX or FRAX Plus, and that will improve sensitivity. So those things are all possible, but it takes a lot to get there in clinical use. We did a study and asked, we were going to do exactly that on our abdominal CT scans for colonoscopy. One of our radiologists is an expert in this, and we do thousands of them a year. And we wanted to do exactly what you said, which is calculate a FRAX score and send it to the primary care. And we asked the primary care, did you want that? And they said no. And I have a case where we had somebody with a T-score of like -4. The radiologist reported that and suggested further evaluation. I was fortunate to be on call when the patient came in with a proximal femur fracture that I unfortunately had to repair. So it was a missed opportunity. So there are gigantic numbers of missed opportunities, and I think as we tap into the potential of these radiologic imaging studies, combine them with clinical data we can abstract from the electronic record, we can start to identify these things, but you're still going to have a problem of who's going to do something about that.
Steps, right?
Because we don't have, even in the United States, we don't have the people who want to take care of it.
Just wanted to say to everybody, thank you so much for coming to this presentation. The important thing is we can do better for our patients. We must do better for our patients, and it takes teamwork. And so this isn't just the spine surgeons. This is especially our medical cohorts who are able to implement the change, start the conversation, and we need to educate all, the patients, the providers, the payers, and get to the end result. So thank you very much.
Right.